Thanks everybody for joining us today at Research and Discovery Grand Rounds. We're going to get started in just a few minutes, actually just about a minute from now. We're really excited to have you here. We've got a fantastic speaker. This opening slide that you see on your screen, you've got a minute now to log into frontierctsi.org and become a member if you aren't already a member. Being a member keeps you up to date on current events with Frontiers, and also creates some eligibility for access to resources from Frontiers, including pilot funds that may be coming up in the future. So make sure you're a member and invite all your friends and relatives to become members too. Provided they're clinical and translational researchers. We want to get all of our researchers on board. So we'll get started here in just about a minute. There's also a direct link for joining if you click into the chat. If you're not a member, click on that link in the chat and become a member of Frontiers. Okay, give us the next slide, Ashley. Also, while you're signing up for membership, block out our next Research and Discovery Grand Rounds on your calendar. It will be Thursday, March 23rd at noon, our usual time and place. And we will actually be delighted to talk with Andrea Bradley Ewing about the value of community engagement in translational research. I think you're really going to be excited to hear what they've been up to in the Kansas City metro area with some applied research activity. And we'll get a chance to hear more about engagement of community advisory board members and how to take advantage of that. A great resource, some really interesting work that they're doing. So please join us in March. Without any further ado, then I'd like to actually introduce our speaker today. John Spertus is a cardiologist in the Lauer, Missouri Endowed Chair and Professor of Medicine at the University of Missouri, Kansas City, and serves as the Clinical Director of Outcomes Research at St. Luke's Mid-America Heart Institute, or MAHI as we call it. He's a graduate of UCSF Medical School and completed his internal medicine, cardiology, and health services research training at the University of Washington. He has served on numerous national committees for the American College of Cardiology, the American Heart Association, the AMA, the National Quality Forum, and other places. His research activities led to his induction into the American Society of Clinical Investigators in 2006, the Association of University Cardiologists in 2018, and his receipt of the American Heart Association Quality of Care and Outcomes Research Council's Distinguished Achievement Award. And he was also awarded the AHA a Lifetime Achievement Award in 2015. He founded the Cardiovascular Outcomes Research Consortium and CV Outcomes, a nonprofit corporation dedicated to advancing healthcare quality and outcomes research in cardiovascular disease and health outcomes science, a biotech firm that he started up. According to Google Scholar Metrics, Dr. Spertus has over 500 peer-reviewed publications, and his work has been cited almost 200,000 times. He's been named by Thomson Reuters as one of the most influential scientists in the world, among their most highly cited authors. He's devoted his career to improving the quality and patient-centeredness of care. His research focuses on methods for assessing patients' health outcomes, measuring healthcare quality, and the use of healthcare information technology to guide medical decision-making on risk prediction models so that treatment can be safer, more cost-effective, evidence-based, and patient-centered. Particular note, he developed the Seattle Angina Questionnaire and the Kansas City Cardiomyopathy Questionnaire, which have both been translated into over 95 languages and have become the gold standards for measuring patients' symptoms, function, quality of life, and coronary artery disease and heart failure. While he collaborates with basic scientists to illuminate the prognostic significance of genetics and biomarkers on cardiovascular outcomes, his primary focus in the translational research enterprise has been at the interface of patient care. In spite of his numerous accomplishments, he has also made himself constantly available to support the careers of junior investigators, particularly as they work in health services research and patient-centered outcomes measurement. Without any further ado, I will turn it over to Dr. Spertus.
Well, thank you very much. I guess I don't have much time left after that lengthy and very generous introduction, so I will nevertheless proceed. And I'm going to be talking about sort of where I think the future is going and why it should go that way in trying to integrate the patient's voice into actually clinical care as opposed to just as endpoints in clinical trials. And so these are my disclosures, and the most relevant disclosure is that I've developed and have the copyright on several patient-reported outcome measures that are licensed. So let me just have you think about a new revolutionary test. In medicine, we're always thrilled with some new imaging modality, a new biomarker. And if I had a test that could actually define the status of a medical condition and improve the accuracy of its assessment and improve the clinical efficiency of caring for patients, that would be amazing. If I had a test that could risk stratify prognosis, that would be very valuable in clinical practice. If I had a test could figure out which patients benefit from treatment and tailor treatment to those who most benefit, that would be a huge accomplishment. If I had a test that could monitor the response to treatment over time, so we continually tailor, intensify, and modify treatment to improve patients' outcomes, that would be enough. If it could support population health management, so we could increase the value of care and be more efficient in managing not just the patient before us, but all the patients in our healthcare system, that would be fantastic. And if it could define the quality of care so that we could use that continually improve the quality that we deliver to our patients, that would be great. And I know it sounds like I'm talking about a tricorder, and I don't want to be a total Star Trek geek, but really, this is what patient-reported outcomes can allow us to do. And so that's what I really want to review here. And, just to give you a conceptual framework, PROs, or patient health status measures, are trying to quantify what the patients experience. So in coronary artery disease, I'm a cardiologist, so all of this is going to be around cardiology. There's an underlying disease process, whether it's epicardial coronary stenosis, limiting blood flow, microvascular dysfunction, inflammation. These are processes that are going on, but none of us know if we have a 30% or an 80% stenosed coronary artery. What we experience are the symptoms of angina, the chest pain that comes from having to exert yourself more than the blood supply can support. We know how that angina limits us physically, emotionally, socially. And, our quality of life is sort of distinct from all of these, because you could imagine two patients, both with having angina 2 or 3 times a week, climbing a second flight of stairs. But if one is a 42-year-old construction worker and the other is a 72-year-old widower, the construction worker is going to have a terrible quality of life because her angina is preventing her from working. None of her friends have this, and her quality of life would be terrible. But the older person might not mind waiting for the elevator. Other people are sicker than him in his peer group, and so he might have an excellent quality of life. And so distinctly measuring each of these components of the way the disease impacts patients, I think, is very important, not only to get a complete assessment of the impact of the disease, but also as clinicians, we would treat somebody differently who had a lot of angina and poor quality of life, and we would focus on treating the angina versus somebody who had no angina and a terrible quality of life, and we might think about, depression or other conditions that are impacting their interpretation of their disease. And so all of these symptoms, function, and quality of life is what I mean when I talk about health status. Now, there are questionnaires that are completed to measure these, and I'm not going to go through any of the psychometrics involved, but know that there's a lot of scientific rigor that goes into establishing the validity, reliability, responsiveness, how you interpret scores, and to translate these instruments into different languages and cultures. And, the two I've been most involved in is the Seattle Angina Questionnaire for coronary artery disease. And this is either 19 or 7 items. And what it measures are those things that a clinician would ask if they saw a patient in clinic for their coronary disease. How limited are you due to your angina? How often are you having angina? How much is it impacting your quality of life? Has it changed recently? And given that there are many ways to treat patients with coronary disease, are you satisfied with your current treatment? And while we originally developed this, not, sort of creating a summary score, the world sort of wanted a summary score. So we do have a SAC summary score that is the average of the physical limitation, angina frequency, and quality of life domains. Higher scores indicate, better function, less limitation, better, no angina would be a score of 100. Scores of 0 would be having angina 4 or more times a day, or terrible quality of life. We've done a lot of work to establish the psychometric properties of the instrument. It's been translated to about 65 languages and cultures, and it's been demonstrated to be associated with prognosis. Now, what's really important also is to realize that the way those scales are designed, they're designed to exactly map on the domains or the manifestations of coronary disease on patients' health status. So it offers additional interpretability beyond the summary score itself. And, these things sound very vague. And what I want to emphasize is that it's actually sort of simple. This is the 7-item Seattle Angina Questionnaire. And what it does is it asks patients in the same way every time over the past month, how limited have you been in walking indoors on level ground, which is a very low level of activity, gardening or vacuuming or carrying groceries, which is a moderate, or lifting or moving heavy objects, which is a more strenuous activity. And the ability to ask the question at the same time every time you see the patient is, I think, very valuable and adds a lot to the reproducibility of these tools. We ask how often they have angina or take nitroglycerin for their angina, and how they perceive it to improve their quality of life. And so, I don't want this to be vague. In fact, when my mom asked me what I did, and I said, well, Mom, I try and figure out, how patients, are feeling and doing and what their quality of life is after treatment. And she looked at me like I had two heads. Like, isn't that what doctors and researchers have always done? And in reality, when I started my career, this was not valued or felt to be important. And I hope this talk will help emphasize how powerful it can be. The KCCQ follows a very similar construct. It also has a total symptom score and a clinical summary score, which was introduced to replicate the New York Heart Association classification, which was the most common way that clinicians would assess the health status of patients. And then there's an overall summary score that tries to capture all the health status of patients. And again, it's representing the patient's perspective, not the clinician's perspective of their heart failure. It's in 110 languages now. Again, we've done a lot to establish the psychometric properties. And, we've gotten qualification by both the drug and the device side for this to serve as a clinical outcome assessment, meaning that a new drug or a new device that would like to get FDA approval, they can be awarded that approval if their intervention improves health status as measured by the KCCQ. And so that's part of why it's the only instrument approved for both drug and devices in cardiac disease. And it's why it's used in so many clinical trials these days by industry. And again, it maps to the same construct that we have outlined before of trying to understand the way heart failure impacts patients' lives. Now, I talked about sort of the outline of what I'd like to present, which is how PROs can be so helpful in clinical care. And, the first is really trying to think about improving accuracy and clinical efficiency. So when I was in medical school and rounding at the VA in San Francisco, we would see these veterans and, we listened to their hearts, and they had all kinds of crazy valvular disease, rheumatic heart disease, et cetera. And who would define what the anatomy and physiology was? It would be the cardiologist with the grayest hair would put the stethoscope on and tell us what was going on, what degree of MR or AI, or how large the heart was by percussing it, or if there was a gallop or not. And this inherently led to lots of sort of variability, and the accuracy and reproducibility was a bit in question. And then along comes the echo, where we have a very clear way to systematically and reproducibly assess cardiac anatomy and physiology. And that's sort of how we evolved in cardiology. Well, who defines the history, the symptoms and impact of a patient's health status? Well, that's the clinician interviewing the patient. And that too, as I'll demonstrate later, has lots of variability in accuracy and reproducibility. And so I do think that PROs are going to be a major evolution in the way we start understanding how our patients are impacted by their disease and how aggressively we treat them. And, really what these PROs are, it's about hearing the patient's voice. And, this is not something we assume we do it well, but I'll show you that we don't always do it well. And so we wanted to figure out how accurately do cardiologists assess patients' angina. And so we did a 24-center study throughout the United States, where these were all in cardiology clinics. So the focus of the doctor is assessing the health status of their patient's angina. And we said, well, we have a patient who's describing to the doctor how much angina and what their health status is, and we could assess that by the SAC. We have the doctor who's hearing the patient, and so we asked the doctor directly, did this patient have daily, weekly, monthly, or no angina? And we tried to compare how well they agreed. And so in this cohort of over 1,200 patients, they're all in cardiology clinics. So 2/3 of them had no angina, which makes a lot of sense because that's what they're there for. A quarter had monthly angina, and 8% had daily or weekly angina. And so what I'm showing you here is of those patients who reported daily or weekly angina, in red is when the doctor said the patient had daily or weekly angina. And they got it right 69% of the time. However, in a quarter of the patients who said they had daily or weekly angina, the doctor thought the patient had no angina at all. And that's a big, big deal. And in fact, the overall concordance between doctor and patient assessments was about 0.48. That was the kappa. And so we were very interested. We thought that doctors would under-recognize angina in Black patients. They would under-recognize it in women. They might under-recognize it in older patients. So we looked at what predicts the under-recognition of angina. And, it turns out really none of these patient characteristics influence it. The thing that was most strongly associated with the under-recognition of angina was the doctor who saw the patient. And a median odds ratio of 2.6 means that on average, the same patient going to two random doctors in this study was 2.5-fold more likely to be under-recognized by one doctor as compared with another. And this shows the doctors who saw more than 10 patients in the study. And the doctor at the far left, in the number one doctor, never under-recognized their patient's angina. The doctor at the far right under-recognized 84% of his patient's angina. That kind of variability underscores the value of systematically collecting PROs in routine clinical care. And as you can imagine, there's a consequence to under-recognizing angina. We looked at, what was the predictors of escalating or not escalating treatment. And it turns out that, as you would expect, if the doctor didn't realize the patient had a lot of angina, they were almost 90% less likely to do additional testing or to intensify anti-anginal regimens. And that was the most important, by far, predictor of not escalating treatment. The New York Heart has long been used to measure the health status of patients with heart failure. And this was some work that Steve Green did in 5,000 outpatients with HFrEF. And he looked at the change over time. And what you see here is that, over a year, most doctors using the New York Heart did not think their patients had changed much. But when you use the KCCQ, you see a much broader distribution of change, which I think is a more realistic way of how patients get better or worse over time, over a year of treatment. And so it underscores the insensitivity of physician-assessed as compared with patient-assessed health status. And, when you look at what's more important in predicting subsequent death and hospitalization, it was actually the KCCQ was strongly associated, changes in KCCQ were strongly associated with death or death and hospitalization in both adjusted and unadjusted analyses, and New York Heart was not. Moreover, when doctors have access to the KCCQ, they can be more accurate in assigning New York Heart class. So this is a study. Alex Sandu is somebody I mentored and collaborate at Stanford, who's been implementing the KCCQ in clinical practice at Stanford. And so this is a randomized trial. And, half the patients, the KCCQ was shared with the doctors, half they weren't. And the correlation between the KCCQ and the New York Heart was far greater when the doctor was able to review the KCCQ scores than when it was not. And this shows the distribution. And if you look at those with a New York Heart Class 3, there is a narrower distribution of KCCQ scores that are more heavily weighted in the group that has a KCCQ score in the range of New York Heart Class 3. And the blue dots, which are the usual care arm, there are patients being called Class 3 with KCCQ scores near 100, as well as those with scores, near 10. So this, I think, shows that it can improve the accuracy of and efficiency of assessing patients' health status. We often are trying to risk stratify patients. The cornerstone of precision medicine is identifying who's at higher risk that you can treat more aggressively. And, we've been demonstrating for now 2 decades that health status is very good at risk stratifying patients. So, this is from the Ephesus trial, and it shows that, patients who have a baseline score of 75 to 100 versus 50 to 75, 25 to 50, or less than 25 have very different risks of cardiovascular mortality and hospitalization, such that almost half have been hospitalized or died in the lowest group, compared with only 10% at 6 months in the highest group. And this isn't rocket science. I mean, patients who are sick are more likely to have events, but we've undervalued using the patient's voice to describe how sick they are. And that's what this highlights. In fact, in a fully adjusted risk model, the strongest predictors of death and hospitalization are patients' self-reported KCCQs. Mikhail Kosoboro did some work that basically showed that a 5-point change in the KCCQ over 2 months, so this is reflecting sort of outpatient monitoring of patients, is associated, even in a fully adjusted model, with about a 10% increase if it goes down, or a 10% decrease if it improves, of death and hospitalization. So if you're going to use the KCCQ in practice, and you saw the patient before, and you had a KCCQ score, and you're seeing them today in clinic, what should you pay attention to? What best estimates prognosis? Is it the first score? Is it their current score? Or is it the change in score that they had? And does it vary if the patient has heart failure with reduced or preserved ejection fraction? And so one of our T32 fellows, Yashu Pakaral, took the data from TopCat and HF Action, which is a HFrEF and a HFpEF population. And he built risk models. And what you see is that when you adjust or don't adjust, so this is looking at the first KCCQ, there's very little impact on the association of the KCCQ with prognosis after adjustment, meaning that these health status assessments are capturing something very different than blood pressure, BNP levels, ejection fraction, other things that we use clinically, because it's a unique variable, and that's very valuable. It's also clear that, I know this is confusing, but the prior KCCQs associated with prognosis, the current one is associated, and changes. They're all associated. But when you include a model that has prior and current health status, in the adjusted model, it is the current health status, not the prior health status, that is most strongly associated with prognosis. Similarly, in a model with change and current health status, it is the current, not the change, that's most important. So what this means is that every time you're assessing the KCCQ in clinical practice, you're getting a continually updated model of the patient's prognosis over the next year. Identifying which patients benefit from treatment. This is a very important thing. So many clinical trials, and in fact, in coronary disease, will look at, disease progression outcomes, the occurrence of heart attacks, heart failure, death. And the goal there is to make patients live longer. Does treatment improve patient survival? Increasingly, we're starting to capture health status. And this is what I've been talking about. And it's really the goal of trying to make patients feel better with treatment. And frankly, this is often what patients most care about. So, we recently conducted the ischemia trial, which was an enormous $120 million NIH-funded international study comparing a strategy of sending patients with high-risk ischemia to the cath lab or managing them with medicines alone. And there was no impact on clinical events, and mortality was completely overlapping. But there was a clear benefit on health status as assessed by the Seattle Angina Questionnaire, where in red, you see after randomization that there is a higher health status over time out to 4 years compared with conservative therapy alone. And, I don't know how many of you are cardiologists, but in cardiology, the foundation by which we figured who to send to the cath lab or not was whether they had a lot of ischemia. And in the ischemia trial, we had, by a core lab, some patients with no or mild ischemia, some with moderate, some with severe, and there was no association between the magnitude of ischemia and the benefit of an invasive strategy. In fact, the magnitude of ischemia did not even risk stratify well the prognosis of these patients who were managed medically. In contrast, this is a graph showing the likelihood of having no angina at 3 months as a function of your baseline SAC angina frequency score. And so the way to interpret this is if somebody has a score of 50, they have about a 15% chance of having no angina 3 months later if they are treated with medicines alone, and they have about a 45% chance of being angina-free 3 months later if they undergo an invasive management strategy with angiography and revascularization. And that difference is so large that you only need to treat 3 patients by sending them to the cath lab for 1 patient with a baseline angina frequency score of 50 to be angina-free. In contrast, if the patient has no angina, then there is no difference in their likelihood of being angina-free at 3 months, and the number needed to treat is infinity. What this is demonstrating very clearly is that you can risk stratify the benefits of an invasive management strategy by using the magnitude of angina that patients have prior to treatment using a PRO or the Seattle Angina Questionnaire. And this holds to 12 and 36 months. In light of a lot of this work, the updated guidelines for revascularization, which have been fairly controversial, and I can answer those in questions, came up with, sort of 10 key take-home points. And number two in their take-home points are that treatment decisions should be patient-centered. They should incorporate patients' preferences and goals, and they should include shared decision-making. And so what we've done is we said, well, look, the guidelines are demanding this. We've just conducted this enormous, trial in ischemia to figure this all out. Why don't we create a patient-specific, patient-centered shared decision-making tool from the ischemia trial? And so to do this, our first phase was to figure out what outcomes are most important to patients. I mean, if you've got a lot of ischemia and significant coronary disease, what do you want to know to decide if you should go to the cath lab and get angioplasty or bypass surgery, or you should try medicines alone? And how should we present that so it's most understandable to patients, and to get iterative feedback on a potential patient decision aid? So it turns out patients most cared about quality of life and longevity, followed closely by function and symptoms. And so this is done through 6 different focus groups in New York and Kansas City with a wide variety of patients. And underscoring the importance of quality of life, one patient said, forget longevity, it's the quality of life today. Supporting longevity, somebody said, I don't want to die. I want to live and see my grandchildren get older. I want to see my daughter live her life. Supporting function, somebody said the feeling of being able to walk 45 minutes again, and I feel stronger as I'm walking, that's a joy that you take for granted until it's almost taken away from you. And supporting, the importance of symptoms, I've never had another chest pain, angina, nor do I ever hope to get another chest pain again. And interestingly, a lot of the outcomes we often think about, like heart attacks, repeat revascularization, didn't rise to be in the top 4 like these did. So we looked at different displays. How can we do it? And in the far right is, what has traditionally been used as decision aids, and people did not like that. What they liked more were the speedometers and the health meters, which are shown in the center. And so we then, did additional focus groups testing for comprehension and additional preferences for the visual displays. We got feedback from practicing cardiologists, practicing surgeons, interventionalists, and the trialists that were involved in the ischemia. And we iteratively improved until we created a final tool. And the way we envision this working is we want this to be customized to each patient. So we have built risk prediction models. And so you will be able to enter some of these key variables, as well as the baseline Seattle Angina questionnaire for a patient. And then you will generate a 1-page shared decision-making tool that looks like this, that will describe in lay terms, what is coronary artery disease? How can it be treated, and what are the risks of the procedure? And then what are the benefits, so that you can see if you start, your quality of life is 50 today, you're going to be 65 or 70 if you choose to get medicines or medicines plus an invasive angiogram and revascularization. And you can see that for physical function, the amount of angina, and the chance of being alive in 4 years. And so this, we think, is going to be very valuable, and we're making it free on the web so that we can start to figure out, and this is the next big challenge, how do you implement or integrate this into routine clinical practice? And that's a very hard task to do, but something we're going to do. PROs are ideal for monitoring response to treatment. So, you have a patient, you saw them in June, you see them in August, and they've had minimal improvement with intensifying their medicines. Do you want to intensify their medicines more? Do you want to offer cardiac resynchronization therapy? Maybe you do offer CRT and they get a lot better, but they're still not at 100. So do they need further optimization of settings, additional medications? In fact, what we really think is that there are lots of new treatments for heart failure. And they all basically have similar relevant risk reductions in death and hospitalization. So why don't you pick the best therapy for the patient based on their quality of life? This is, in essence, testing in each patient by using the KCCQ before and after you treat them, And the advantage of that is that if the patient improves, you continue the treatment, and the patient knows why you're treating them. Your KCCQ score is 50. I think you could get a lot better if we start you on this SGLT2 inhibitor. And so now that they understand it, theoretically, they'll be more adherent to their medicines because they're part of the team caring for them. And if the patient doesn't improve, you try something else. So diagrammatically, you have a patient with stable heart failure, you get a KCCQ, you intensify therapy, you get a follow-up. If their KCCQ is 5 points or better, you continue it. And if it's not, maybe you try something else. To me, this seems like a very logical way of trying to care for patients. And I've had the privilege of working with Kelly Bozak at KU, starting to think about how one might go about implementing something like this. You know, I also think that these things could be used for population health management. I'll give you two examples. You know, nothing upended our healthcare system like COVID-19. And we went nuts in rapidly changing from all in-person visits to telehealth. And one of our residents published this paper recently that described the telehealth model at St. Luke's. And so what you see is, something didn't show up here. Gosh darn it. I lost something, sorry. But basically, you know, in 2018 and 19, 100% were in-person visits. In 2020, 88.5% were virtual visits. And what you see is in March of 2020, we rapidly stopped in-person visits and markedly increased the virtual visits. But as soon as the shutdown ended, we went right back to decreasing telehealth and increasing the in-person visits, such that now we are over 95% in person and don't use telehealth anymore. And to me, telehealth could be far more convenient and helpful and more patient-centered, because why should the patient drive in, spend their whole day waiting to spend 5 minutes with you if they're stable and doing well? So why don't you get a KCCQ before the visit? And if it's, you know, not worse, then you could offer a telehealth visit. And if they are significantly worse, you could do an in-person visit. To me, this is a way of trying to think about the more rational allocation of resources, designing more efficient care, and improving the value of healthcare. You know, this is an old study. It's, you know, from 2006. So it's almost 20 years old. But John Beltrami was very interested in, like we did in the cardiology study I showed, basically replicated this, where, you know, he surveyed 207 primary care physician practices in Australia. He had them, you know, on the next 10 to 20 patients that came through clinic for coronary disease, regardless if they were there for their angina or if they were there for a flu shot, had them complete the SAC. And then we looked at the proportion of patients who had weekly or more angina and graphed the percent of each practice's patients that had a lot of angina. And what you see here is across these 207 clinics, there are some practices where none of their patients had daily or weekly angina. And there are other practices where over half their patients had daily or weekly angina. You know, have those patients even seen a cardiologist in the last 10 years? I mean, again, you know, the ischemia trial would suggest we should not be doing revascularization or invasive therapy in patients who have no angina. But I would argue that in routine clinical care, there are lots of patients in this study, almost 22% of patients in primary care clinics who have coronary disease have daily or weekly angina. And to me, we ought to be proactively identifying those patients and bringing them in for an evaluation of potential revascularization to try and improve their outcomes. Finally, there's an increasing movement to use PROs to define the quality of care. You know, and the logic is that, you know, how well our patients are doing in terms of their symptoms, function, and quality of life should be a direct reflection of the quality of care we're providing to them. And it turns out the quality of care is very valuable, very variable. So in CHAMP-HF, we had 150 centers, cardiologists, heart failure specialists, internal medicines, and family practitioners that enrolled 5,000 patients with HFrEF. We looked at what proportion of patients had a KCCQ overall summary score greater than or equal to 75, meaning good to excellent health status. And then we adjusted for 28 patient characteristics to look at the variability, the median odds ratio across practices. And this is what you see in the 98 clinics that saw more than 20 patients. There were some clinics where none of their patients had excellent health status. Some where almost 80% did. And the median odds ratio was 1.7, meaning that the statistically identical patient going to 2 random clinics in this cohort would have had a 70% greater chance of having excellent health status at one random clinic versus another. I mean, that's a huge deal. And to be able to measure and quantify that and create an incentive for clinicians to be more aggressive in treating their patients to improve their health status, exactly what the IOM has challenged us to do by creating a higher value healthcare system that is more patient-centered. And accordingly, the International Consortium for Health Outcomes Measurement for coronary disease and heart failure have endorsed the KCCQ and the SAC, as well as other PROs, as ways of measuring and tracking the quality of care being offered in practice. So the final frontier is figuring out how to integrate these tools in practice. I've spent the last part demonstrating why we should. And, it's basically, if it increases the accuracy and efficiency of care, it helps us risk stratify prognosis and to identify treatment benefit, to monitor responses to therapy, and to, eventually it's going to be required for quality. CMS is developing those. Why don't we start just integrating them in care so that delivering the required performance measures for Medicare or other payers is a byproduct of delivering more patient-centered care? And so I think we've got to figure out how to do this. And, at University of Utah, they did it, and patients really liked it. They did a qualitative study of 24 patients, and, 23 strongly agreed that by filling out the KCCQ, it gave their providers a better sense of their heart failure. And 16 stated that it was helpful for them in talking to their doctors about their heart failure and its current management. And 22 felt that it improved their care. But 17, over 2/3, felt that more attention should be given to their KCCQ scores in the clinic visit. And, basically, the patients felt that the use of PROs was important, but particularly if the doctors used them in their visit. They were frustrated if they weren't discussed. And so, from the patient's perspective, they wanted. So this is work that Alex Sandhu has been doing at Stanford on insights on the implementation. So we did a lot of qualitative research. And a key theme that emerged was the importance of having an engaged clinical champion. The implementation lead, which was Alex, was very hands-on with this project. It wasn't like, okay, we're going to go do this and here you go. He was very passionate. He was always providing himself as an available resource, checking in emails. He was there throughout the whole thing, and I think it helped for sure, said one of the doctors. Experience is key. As they start using it, they like it. Yeah, I was going to say, obviously, the more you use it, the more comfortable you get, and the better you understand what each individual score means, because you've been in more and more positions where you've seen a score in that range and you've seen a patient and heard a similar story. So the idea that you start to imprint what a score of 20, 40, 80 means comes with the experience of using it in multiple patients. Integrating the workflow was really important. I did initially find it time consuming compared to what the other tools that we have, but now that I look at it, I don't think it's time consuming because the information we gather from it is valuable. Having this score show up in Epic is fine because it's easy for us to locate it and put it in a place where we open the chart so that we really see it was sort of guidance about integration into workflow. how providers see the use of the KCCQ actually helping care. One said, this is standardized history taking, which is what I articulated earlier in this talk. I think it's very helpful. I think, it's very helpful because, like I said, I think that my history taking can be a little bit variable from how the AP does it or from how someone else does it. But I think the nice thing about the PRO is it standardizes that to a larger extent. Another provider thought it helped patient communication. The times that I look to see as a way to see if anything's changed from their baseline. If I know the patient well, and if they've never had issues with fatigue, and all of a sudden they've been fatigued for the last month, I would then make sure that I address that in more detail than I normally would. This is about improving the efficiency of care by looking at the scores before you walk in to see the patient. Engaging patients in additional therapy. But there are patients who are skeptical. I find that the patients who have skepticism and fear of moving forward with a procedure, especially a procedure that carries risks, having the data can be very helpful. I would kind of explain where they are and say, look, your quality of life is X. I think we can get it to Y. I think we can dramatically improve it. And if we look at all comers, this is kind of my concern. I find it very helpful in those patients. And then finally, how the providers thought it helped care, getting a more accurate history. And this sort of reiterates some of the points I made earlier. A more complete picture of how the patients are doing. I think it's helpful for me, for patients when their objective data is discordant with how they're feeling. So meaning that from their echo or their lab values or the exam, they seem to be, those things perhaps underestimate the severity of their heart failure. So I think the KCCQ can be an important data point there. I think less so if all the other objective data shows the patient sick or decompensated, then the KCCQ be accordant with that, not necessarily adds as much. So yeah, I think it's kind of helpful in that way. And somebody else really talked about how it was helpful, and that in the same way that if the person had several KCCQs, it gives you a sense of their longitudinal trajectory, and they use it in the same way. So, pulling for this, if we are going to implement it into care, the key considerations, I think, are identifying a clinical champion, educating, and holding physicians accountable for actually trying and using it. Figuring out the mechanics of how to integrate it into workflow, how to collect it. Is it through the patient portal, text messages, through clinic-based clinic tablets? And defining how to present the data, both for doctors, but increasingly for patients, I think is very important. And then defining where to place it in the EMR. I mean, it seems so mundane, but if it's several clicks to get to it, nobody's going to use it. I think it should be on the opening page with the blood pressure and pulse and weight. But, again, this is customized to each practice. So I'm going to end here and just say that, I really think PROs have enormous potential in impacting care, and we just have to start doing it. And the more we do it, the more we'll get used to it. And I think the more value it will bring. So thank you very, very much for your time. And I'd be really happy to address any questions you might have.
John, thanks so much for a fantastic presentation. All those, you really laid out multiple areas of future research potential. I mean, not all of us are cardiologists, but applying these principles to a variety of other conditions creates opportunities for developing new patient-reported outcome instruments. You showed us a wealth of research in utilizing those instruments to correlate with different types of therapy and patient wellness status. And then certainly you're challenging us on the implementation side at the end, and lots of different opportunities, both from the patient and provider's perspective, for furthering implementation research. Feel free, if you're online, to go ahead and unmute yourself and ask a question, or I don't know, you can probably raise your hand or put something in the chat. I have a couple of questions I wanted to ask, but I could pause for a second here. So, John, could you tell us a little bit about potential counterbalancing measures? So let's look at the heart failure questionnaire that you developed and the medications that you use for heart failure. And maybe this would apply more if we were doing something in peripheral neuropathy where there are these really distinct adverse effects. But is your heart failure questionnaire able to capture adverse effects of medications? Or could you actually be improving somebody's symptoms in heart failure while at the same time worsening symptoms in a different dimension, like dizziness, fatigue, or passing out?
Yeah, so it's a great question. There are two broad, classes of disease-specific measures. There are generic disease-specific measures, and there are generic measures and disease-specific measures. And generic measures look at sort of all of the manifestations of a disease, and a disease-specific focuses on one. And in general, I find the disease-specific measures to be far more sensitive to a specific treatment, because if I'm treating somebody for heart failure, I'm not trying to improve their arthritic pain, and their generic measure might be influenced a lot by their arthritis and show no benefit despite a significant improvement in their health status with regards to their heart failure. And so these tools will be very good. The disease-specific measure tools will be very good at capturing the specific disease they were designed for, but not for manifestations of the disease outside of heart failure, which would require a generic or other kind of measure. And there are, the PROMIS tools have emerged as sort of a very efficient way to do it. I think they're hard to interpret, frankly, but maybe it's just because of my lack of experience. But one of the things that's been very nice about the disease-specific measures is they are in the framework with which a clinician treating those patients is thinking, and so it makes it more actionable by the doctor. I mean, I used to use the SF-36 all the time, and I still have no idea what to do if a patient has a change in their role emotional functioning or their vitality score. I mean, I just don't know what that means, and I don't know what I do about it, but I sure know what to do if their SAC adjunct frequency score has dropped by 40 points, or their, KCCQ has changed for the better or the worse. And so to me, I think I really like the disease-specific measures, but if you're looking for disease side effects, you're going to need different tools or basically just a good history.
Okay. Yeah, I didn't know if in the generation of these measures, like, for example, if someone was developing a peripheral neuropathy questionnaire, if they would potentially look at some of the anticipated adverse effects of drug therapy in that, or if you'd have to use two different instruments. Everybody's gabapentin right now, and I actually I wondered if we had more better PROs here, if we could actually get some of them back off of it.
Well, I do think that if you're dealing with so we designed our tools to think about the impact of the treatment for that specific disease. So if peripheral neuropathy has several treatments that have different side effects, capturing those side effects would be a good component of a disease-specific measure, because the treatment is highly aligned with that specific disease. And so, but I would consider that a disease-specific measure. It just wouldn't capture a rare one-off side effect, itching eyeballs. Like, it's just not going to pick that up if, 1 out of a million patients gets it. It's not a common thing.
That's very helpful. Other questions? I've got a couple more, so I'll keep talking. Just interrupt me, anybody. So the other question is in talking about de-escalation. I think we've talked before with some of our colleagues about that. We've got everybody on 1 million medications, and we just keep adding more and more. You talked about the ability to actually use the questionnaire to potentially stop a medication if they didn't respond. I was curious as to whether or not that's actually been done before, and whether or not the intra-individual variability is too high. How tight is the intra-individual variability over time to allow you to assume that that no change really was no change, or that a change really was something and not just random variation?
So I didn't show you, to leave more time for questions. I have some slides that actually go into how much you have to change on the questionnaire, how many shifts to the right or left you need to have in order to change by 5 or 10 points. And it's not easy to move that many points. I mean, I think as a clinician, just the face validity of watching somebody go from shortness of breath several times a week to none over the past 2 weeks, you would view that as a clinically important difference, and that would change your symptom score by, I think, 8 points, and your overall score by 4 points, not the 5-point threshold I was recommending. So, you would need to have multiple domains move that much. And, but, this is a brave new world, right? I mean, we don't know what's clinically useful. And when you're integrating clinical care, you want the KCCQ or the SAC to be a supplement to the clinical history. You want the doctor to have a better understanding of what the patient's feeling. But these tools are not perfect by any stretch of the imagination. And even though the intra-class correlation coefficient in stable patients is about 0.92, which is very, very high, there's still a lot of intra-individual variation. And so if somebody wakes up in a bad mood and fills it out differently than they did last time, you have the opportunity in clinical practice to probe and really understand if you think this is a real change or not a real change. And if you do believe it's a real change, then altering therapy in response to that change makes a lot of sense. And whether you choose to alter therapy at a threshold of 5 or 10, it's, up to you. And I think it's going to be really challenging when we do this in the real world. And we put patients on beta blockers and their KCCQ gets worse by 10 points. But we know that beta blockers are sort of a cornerstone of heart failure therapy and to prevent death and hospitalization. What are we going to do? And, my initial thought would be to go to an SGLT2 inhibitor first and come back to the beta blocker another time because the patient's feeling worse. But, there's going to be some very interesting challenges that I have simplified here. And that's why we've got to figure out how to start to implement these things and get that experience and learn. And, it's exciting, but there's still a lot of work to do.
Well, I think Aaron's actually asking a very interesting question that may have implementation aspects to it. Aaron, you want to unmute yourself? And clarify.
Especially because I don't know what the fate of the mini mental status exam is. So,
well, I think Aaron, do you want to clarify? Or do you want me to do it? So I think the issue is that we've been concerning about being able to identify early dementia or mental status deterioration in our patients. And so we've had the mini mental status exam available for a long period of time, but it hasn't been regularly implemented in clinical practice. And so I think I think this is an implementation question. Though the many stat, and part of the reason this may be an implementation question is because the MMSE requires the clinician to actually administer the test, as opposed to the instruments that you have, I think are all patients self-administered. So they can actually be done even before the patient shows up into the office if you send them out through the patient portal.
Yeah, no, that's exact. So the last phase of my talk was really trying to highlight how one goes about successfully implementing it. And it is hard. I mean, look, you guys have great cardiologists at KU. And, a number of them have been practicing for 1 to 2 decades. And you want them to change the way they're conducting their visit. That is not easy to do, and, so it really does take it really requires an implementation science framework to figure out how to get this used. I do believe because it ultimately gets perceived by a lot of doctors after they try it and get familiar with it to make them more efficient in clinic, which is really helpful to them, then it will have a lot of traction and sustainability. But getting over the activation energy to try it is a big deal. And if the doctors aren't really asking for it, wanting it to be used for the patient who didn't fill it out in their portal, the MAs aren't going to have them fill it out in the waiting room, So there's a lot of implementation challenges here. And, I would argue you probably didn't have as full and complete and as successful an implementation effort in the MMSC that you should have if it's just not being used. And, it's heartbreaking to me when the hardest thing, I mean, I just think research is so easy until you try and really get it used in clinical care and implement it. And I've been doing this for a long time. We started implementing risk models in the cath lab. And, despite all the evidence we could bring to bear to show how to improve patient care and outcomes and all the benefits, we just, it's hard to sustain it. You really, you just need a strong culture that values it, and you've got to figure out how to instill that culture in the group if you think this is really important for improving the value of patient-centeredness of care.
Aaron, I think you got unmuted. Did we cover that, or any clarifications you wanted to make with your question?
Oh yeah, thanks for your attention to that question. I think one of the MMSE was a very easy to administer tool that was validated early on several decades ago. That fell out of disuse because people were saying that it was not open source, that it was a copyrighted material, and that therefore it was pay for use of the instrument itself. And then so that would be an obstacle to implement or putting that into a electronic health record. So that would be between the different companies, different EHR companies. So I was kind of, I'm hopeful that these things would be in widespread use, but I was just kind of curious, how do you avoid that type of a problem?
Well, you ultimately, so I didn't know the MMSC was copyrighted. That's interesting. We copyrighted the SAC and the KCCQ. The question is, how do you create a sustainable business model to build a PRO, right? I mean, the promise scales, which are open source, although you have to buy the, I forgot what it's called, but the API to get it scored if you don't want to build it yourself. Even though if you build it yourself, you don't have to pay for it. But, realize that has had 2 decades and probably $80 million of funding over time. First by NIH, so they couldn't afford any more, then by PCORI. And, they got a multi-million-dollar grant just to build the business model to sustain the PRO, so they didn't have to keep getting NIH funding for it. Like, each of those translations costs, $15,000 to $25,000. Like, how do you support an instrument if there's no ability? And so, I'll be totally transparent. The cost, for doing a SAC or KCU clinical care is probably less than a quarter. And a BNP is $60. An echo or a 6-minute walk tests are $800 and $150 respectively. There's somehow a devaluation of the effort it takes to build these PROs, and the recognition that there has to be some way to support it. I mean, there's just no other way to support the translations, the work. I mean, it's just very hard. And so I've been very, when I built this, I never thought about licensing it. I mean, it just never occurred to me that you would do that. And very early on, somebody came to me to want to do a translation, and when I was trying to figure out how to do it, and it was $26,000, I wrote a $35,000 check to translate the KCCQ into Japanese, because that's a very hard language and culture. Where does that come from? And I wrote multiple grants to try and get the KCCQ funded, and nobody would fund it. It wasn't considered important research, so we bootstrapped it. And so that's why there's a license fee for that. And, a lot of people don't use it for that reason. But, I don't know what to say about that. We never have let cost be an obstacle to its use. And it's just been a very, it's an awkward thing for somebody who sort of devotes their career to, trying to improve the value of patient care, to charge for something, but there's no other way to sustain it that I can think of. And I don't know the MMSE's background. The SF-36 was built on public funds, and somehow John Ware got it copyrighted, but there's a VA version that's free. So I don't know. I mean, that's a sticky wicket.
Well, thank you very much. Thanks everybody for joining us today. Really appreciate it. And don't forget to come and join us again for our next session in March. John, wonderful presentation. Great question. Thanks, Aaron. Really appreciate everybody joining us.
Thanks so much.